How's it going, guys? So this is a pass level diagnosis for step 1 and step 2. If you're having trouble with this, you are going to have serious fucking issues on your exam. Okay? Allow me to be an asshole and fearmonger like I do in some of my clips. All right? And then, of course, we've got some more difficult answer choices here regarding mechanisms of action, but still fucking hyper basic. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like, really appreciate it. Find me on Instagram, Mehlman_medical, MEHLMAN_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the fucking clip. So 24-year-old dude, today history, dry cough, low-grade fever, 100 Fahrenheit, serum cold agglutinins are positive. Chest x-ray shows us patchy interstitial infiltrates in both lobes. Radiology does not, fuck am I saying? USMLE does not expect you to be a radiology attending where you look at this chest x-ray and you're like, yeah, obviously those are interstitial infiltrates bilaterally. Bunch of nonsense, bunch of horseshit, okay? They explicate for you. Patchy interstitial infiltrates in both lobes. That refers to atypical pneumonia. Lobar pneumonias, in contrast, if they said right lower lobe consolidation, dullness, percussion, that would be strep pneumo, okay? But bilateral interstitial infiltrates, atypical pneumonia, this is going to be virus or mycoplasma. Now, serum cold agglutinins are positive. This means IgM antibodies against RBCs, leading to a cold autoimmune hemolytic anemia, increased proclivity for hemolysis, where you could have increased indirect bilirubin. This is classic for mycoplasma, okay? So this is called walking pneumonia colloquially. You've got this young, otherwise healthy young adult who's just walking around with a bit of a dry cough, doesn't even realize he has a fever, and then you do a chest x-ray and it blows up in your face with all these interstitial infiltrates. This is walking pneumonia. This is mycoplasma. And then the cold agglutinins detail here, very high yield. This clinches our diagnosis. Obviously, we could do, I shouldn't word it strictly like that. We could technically do antigen testing for mycoplasma, but cold agglutinins highly fucking suggestive of the diagnosis. So questions asking mechanism of action of the drug we would use. So why don't we just go backwards through our answer choices here. So inhibition of viral encoding, wrong fucking answer. This is amantadine that could be used for influenza infection. It will not show up on USMLE that way. I just articulate that with regard to what could manifest in resources, okay? That you'll read OMG, amantadine inhibits viral encoding. It's also a Parkinson agent, by the way, increases presynaptic release of dopamine. But amantadine technically could inhibit viral encoding by inhibiting influenza M protein. Wrong fucking answer in this case. Next answer, inhibition of neuraminidase, also wrong. Okay, this refers to oseltamivir or zanamivir, which are sialic acid analogs, okay? They're neuraminidase competitive inhibitors. They prevent viral spread within a community. If you give oseltamivir or zanamivir and you were to do an electron microscopy of influenza infected cells, you would see the cells are packed with virins because the influenza virus cannot leave the cell, okay? You need sialic acid, neuraminidase you need to cleave sialic acid via neuraminidase to leave the cell. The point is, it's the wrong fucking answer. So next one, inhibition of dihydrofolate dehydrogenase. This is leflunomide. This is the wrong fucking answer as well. This is some obscure rheumatoid arthritis drug that's not going to get assessed on USMLE. The only reason I incorporated it into the answer choices here is number 1, to be an asshole, but number 2, when students don't know an answer, they tend to choose weird sounding shit, okay? So this is leflunomide, in case you're curious. It's not going to show up in your USMLE. Next answer, inhibition of dihydrofolate reductase. This is wrong, but otherwise high yield. I mean, you need to know this is methotrexate, which has a myriad of uses. First being DMARD, for the first line DMARD for rheumatoid arthritis, can be used for general chemotherapy, but also psoriasis. Can be Trimethoprim, which of course is with TMP SMX, simple UTIs, pneumocystis jirovecii, toxo, and also pyrimethamine, which is treatment for toxo. TMP SMX is prophylaxis. Point is, it's the wrong fucking answer, so why don't we just move forward? Inhibition of CD20, wrong answer. This is rituximab. This is, you just need to know, high yield for step 1, that rituximab is a monoclonal antibody that targets CD20 on B cells, okay? It's a chemotherapy agent. Also just for Hodgkin sometimes, but also just general immunosuppression. It can have a utility in some autoimmune diseases refractory to other therapies. Next answer choice, inhibition of 50S ribosomal subunit is our correct answer. So the empiric therapy for community-acquired pneumonia is azithromycin, super fucking high yield, and that's a direct answer on one of the new 2CK NBMEs. But even if that weren't the case, it's just high yield overall, okay? I mean, you need to know when a patient has a community-acquired pneumonia, even if you don't know it's mycoplasma, okay? Just patient walks in, you think it could be strep pneumo, could be mycoplasma, Legionella, chlamydia pneumonia, like you're not sure, we still give azithromycin empiric anyway, almost always. Yes, there are exceptions. If patients have been on antibiotics in the past 3 months, other comorbidities, etc., we could potentially think about a respiratory fluoroquinolone, e.g. levofloxacin. But you need to know azithromycin, a macrolide, okay, inhibits 50S ribosomal subunit, super fucking high yield empiric treatment, okay. Macrolides can prolong the QT interval. They can cause GI disturbance. That's the most common cause of non-compliance. Azithromycin does not inhibit P450. The other macrolides do. So, as I said, pass level diagnosis here, mycoplasma, walking pneumonia with the cold agglutinins, and then you give azithromycin as empiric therapy. I'll just finish off these answer choices. Oh, by the way, 50S ribosomal subunit, apart from macrolides, that's also linezolid, clindamycin, and chloramphenicol. Now, inhibition of 30S ribosomal subunit, obviously wrong fucking answers going forward, but that's aminoglycosides such as gentamicin and also tetracyclines. And then formation of toxic metabolites that damage DNA refers to metronidazole, okay? Targets anaerobes below the diaphragm, as well as Giardia, Entamoeba histolytica, trichomoniasis. So, yeah, anaerobes below the diaphragm, metronidazole, okay? Diverticulitis, I made a recent clip on that as well. A lot we can talk about. I mean, what are we going to do? Make this a 1-hour lecture? I know you guys want to see somewhat concise clips here. You know the deal. I'm going to continue making more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.